Welcome, everybody. You are joining the Silver Hill Hospital Grand Rounds. Thanks for joining us, and we will get started in just a moment as people settle into uh, our call. Again, we'll get started in just a moment here. All right. Uh, Hello and welcome, everybody, to the Silver Hill Hospital Grand Rounds program. Thank you for joining us. I'm Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill, and we are absolutely delighted to have you join us, where we are so very privileged to welcome Dr. Mauricio Towen, who will be presenting on the topic of bipolar disorder, comorbid conditions. And I have really the great honor of introducing him in just a moment. But first, as always, a little housekeeping to start us off. Our next Grand Rounds is on March 27th, and that'll be me taking a turn at presenting instead of hosting. I'll be talking about loneliness and connection. This has been a topic of great interest across the country and across the world, and hopefully we can engage in some good discussion and inspiration around a difficult topic. So I hope you all can join us. And we'll continue to come at issues in this Grand Rounds programs that we all think about in mental health, ranging from the spiritual and transpersonal, as we discussed last week, to the biologic and epidemiologic questions, as we'll share today. And please take a look at our upcoming program on the Silver Hill website. It's a great joy to think with all of you about the breadth of our field and the many different ways of understanding and connecting to people. And let us know of any topics you would find interesting for us to explore in this program. For today's lecture, your questions remain a vital part of our grand rounds. I will moderate a question and answer discussion with Dr. Towen at the end of this lecture, and that's a great opportunity to put forward questions and comments to Dr. Towen, which you can submit anytime using the Q&A box. If you wish to receive CME or CEU credits, please complete the evaluation survey that will automatically show up in your browser when we end the webinar. We will also email a copy of the survey to today's participants. Finally, disclosures: no planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest, and Dr. Towen will show a slide with his own disclosures. It is now really my great pleasure and honor to introduce our guest speaker today, Dr. Mauricio Towen, who is a university distinguished professor and chairman of the Department of Psychiatry and Behavioral Sciences at a place I know well, the University of New Mexico. Excuse me. Dr. Towen was recognized in Thomson Reuters, the world's most influential scientific minds 2014. He is one of 100 scientists worldwide recognized in the psychiatry psychology category. Dr. Towen has published over 350 publications, has over 20,000 scientific citations. In 2016, the International Society for Bipolar Disorders awarded him the Mogen Schau Award for Education and Teaching. In 2017, Dr. Towen was recognized by Expertscape as having the top 0.12% expertise in bipolar disorder worldwide, based on citations of published articles between 2007 and 2017. So I did good bringing a great mind to us today, and I know we are all excited to hear Dr. Towen and to learn from him. Beyond all that, something you wouldn't otherwise know, Dr. Towen has been the chair of psychiatry at UNM for some 10 years or so, and I had the good fortune of helping to recruit him, at which point he survived my Mr. Toad's wild ride of a tour of Albuquerque in my attempts to get him to lead our department. Dr. Towen's been really a personal mentor, and I've observed him always thinking about his faculty, what motivates them, and how he can best support their success in the department. I watched as he led us through extremely difficult times with staffing issues, finances, and how to provide care during the pandemic of COVID-19. Above all, he always created a very personal space for me to share what was happening in my life. And I carried a sense that the person I worked for cared for me as a person. And I know this is a gift that has been received for all who work with him. I want you all to know about the personal sense of caring brought by today's speaker, in addition to the depth of knowledge that he will share with all of us. So with that, I have the great honor of passing the baton to you, Mauricio, and thank you. Thank you again for being here.
Thank you, Jeff, especially for the last words you mentioned about me and our relationship. Yes, I very much remember when we visited Albuquerque and you gave us a ride around town. We were sitting in the back, Diana and I, and then you would turn and we were getting a little anxious, but we always remember that welcoming. Again, it's a pleasure to be here, my dear friend, and thanks for inviting me. So folks, thank you for being here today. As Dr. Katzman mentioned, the presentation today is going to be about bipolar disorder and comorbid conditions. As Dr. Katzman mentioned, I've been in New Mexico. It's now 11 years, and I'll tell you a little bit about myself. As you can tell from my accent, I was not born in this country. I was born in Mexico City, and then continued training in Toronto, and then at McLean in Boston. And after that, I was an industry scientist designing clinical trials in bipolar disorder. In addition to, of course, my training in psychiatry, I'm an epidemiologist, and I very much remember my thesis advisor, Ming Swan. He said, Mauricio, if you want to succeed academically, stick to your thesis topic. And my thesis was outcome in bipolar disorder. And this was a number of decades ago. So throughout my career, I have focused on bipolar disorder, again, starting with my training in psychiatric epidemiology in terms of outcome, and then at McLean, got my initial grants. Actually, the first grant that we got was first episode in bipolar disorder. And then, as I mentioned, I moved to industry, design a number of clinical trials in acute mania, bipolar depression, and maintenance. Then I was briefly in San Antonio with the late very dear Charlie Bowen. And then, as mentioned, I came here to New Mexico. New Mexico is a very special place. And I always like to talk about New Mexico every time I have an opportunity. It is a minority state. That means that more than half of us here in New Mexico identify ourselves as Hispanics. It is, in fact, the state in the country with the largest proportion of Hispanics. It also is quite unique because it has a large population of Native Americans, 10%. As I'm sure all of you know, in the rest of the country is less than 1%. That's why it makes it a very unique state. It is top 3 in things we don't like to be top 3. That is education, poverty, and also in terms of mental health. Unfortunately, number 1 in terms of death by suicide in adolescents. So a lot of needs here in New Mexico, and for us, it's an opportunity to improve the lives of everybody in New Mexico. Let's move to the presentation, starting with disclosures. As mentioned, I worked for industry for a number of years, and I continue to provide advice in terms of the design of clinical trials. Of course, we live in a market economy where the academia, of course, the pharmaceutical industry produces a number of medications. So I think it's an obligation that we academics have in terms of uh, providing advice in terms of the studies that need to be done. As you can see, I advise a number of pharmaceutical companies, and it is in terms of study design. So let's move to our presentation. Let's talk first about epidemiology. Actually, it's interesting. When I was getting my training in psychiatric epidemiology, people would say, how is it an epidemic? Well, you do have psychiatric epidemics. And of course, an epidemic just means that the prevalence increases. We are now in an epidemic, as Dr. Gassman mentioned, in terms of loneliness, depression, suicide attempts. I like to continue to do clinical work, not only taking care of patients with bipolar disorder, but also being in the psychiatric emergency service here in UNM Hospital. And I was on call Monday night, and within 5 hours, this was between 5 and 10 in the afternoon, I think we saw about a dozen adolescents with suicidal thoughts. Sometimes we see more adolescents than adults. So yeah, there's an epidemic. The other thing about epidemiology is study the course and outcome of a condition. And actually, when I was in industry, it was very helpful for me in terms of the design of maintenance studies. So the question was, how long should a maintenance study be? You're testing medication, psychotherapy, whatever you wanna test. Well, let's keep in mind that a maintenance study is you wanna see if there's a treatment that will prevent relapses. So how long should the study be? A month? The longer the better, 10 years? The answer is, well, it depends on the epidemiology. And if you look at a curve of relapses in bipolar disorder, you would see that the majority of patients who have an episode of mania, most of them, if they relapse, it's going to be within the first year. So doing a maintenance study of 1 month, not long enough. 5 years, I would say that's unethical, because after the first year, just a few patients relapse. So why is it unethical? Well, why keep patients in a study when you're not going to learn more information? And actually, I can tell you, after we designed that study, most of the maintenance treatment in bipolar disorder have done 1 year. So epidemiology, of course, looks at prevalence. That is the proportion of patients with a condition. So let's talk about the comorbidity of bipolar disorder. I would say that the comorbidity in bipolar disorder is it is actually not an exception. It is the rule. The majority of patients with bipolar disorder suffer from comorbid conditions, a number of them. It can be another psychiatric condition, like anxiety, trauma, or it could be substance use disorder. For that matter, the majority of patients with bipolar disorder, once they have a number of relapses, suffer from substance use disorders. Furthermore, we also have comorbid medical conditions. And many times patients with bipolar disorder, the only time they see an MD is when we see us psychiatrists. And should we be treating their diabetes? Well, ideally, if there's an endocrinologist or a primary care physician, it should be them. But it is key to go where the patient is. And that's why when we have a clinic, let's say clinic in bipolar disorder, we should be providing medical care there as well. Is having being patient-centered, go where the patient is. In addition to that, if we are going to treat a substance use disorder, should we have the patient go to a substance use disorder clinic? Here in New Mexico, it's called the ASAP, alcohol substance use abuse disorder clinic. That's far away. That's not ideal if we have a patient with a comorbid condition. It is better to be co-located. And also when we treat other conditions like anxiety or trauma. So let's look here at anxiety disorder, okay? So as you can see, here you have a number of anxiety disorder conditions. We also have PTSD, and here you have the percents. And this is lifetime. This is a relatively not so recent study, but it is by Mary Kangas in 2007. It is a population study. And as you can see, 70, almost 75% of patients with bipolar disorder have some kind of anxiety disorder. Bipolar 1, 87% of bipolar 1 at some point in their lives suffer from an anxiety disorder. Bipolar 2, actually even more, close to 90%. This is an interesting treatment challenge. So what is the best treatment for an anxiety disorder? Is it benzodiazepines? No. Do they help? Yes, but of course they're addictive. So it is, of course, the SSRIs. So what is the challenge of prescribing an SSRI in a patient with bipolar disorder who also has anxiety disorder? Well, they could it switch, especially when the patient is depressed. Could it switch the patient into mania? It happens, but it's not that common. What it is more common is to develop mixed symptoms. Okay, so there's always that challenge in treating comorbid conditions. Let's now look at substance use disorder, the comorbidity in bipolar disorder. So as you can see, also very high. So any substance use disorder condition, it is, as you can see, in bipolar 1 is 60%. Let me make a comment about the term substance use disorder. Those of you who use DSM-4, which of course was published in 1994, DSM-5 in 2013, may recall that in DSM-4 there was a term abuse, substance abuse disorder, and so on. And studies have shown that if just the terminology, if you use the term substance use rather than abuse, there is less stigma, which means that the patient is more likely to talk about their substance use as opposed to if you call it abuse. So use disorder is a destigmatizing term. Actually, we just went through a trauma-informed care training here at UNM. And you know, it's the importance of using the best terminology. There's always a debate, should we use the term psychiatric condition or psychosis or behavioral health? And there's the argument that if you call it behavioral health, it's less stigmatizing. Also, when we have patients who come to the emergency room and we call them frequent flyers, very inappropriate. The better term is patients who seek resources frequently. So that's in terms of the substance use disorder. Back to the comorbidity with bipolar disorder. Look at this, 60% of patients with bipolar 1 disorder suffer from a substance use disorder, which is larger than bipolar 2. Now, an interesting finding that we'll talk about a little later is what is the percent in the first episode? Is it already 50, 60%, or is it less? And we'll look at that later on in the presentation. Now let's look at the predictors of lifetime of having alcohol dependence. So can we do preventive medicine in psychiatry? Fortunately, yes. And this is an example. If a patient with just diagnosed with bipolar disorder, is there a chance of later developing alcohol dependence? There certainly is. But then when you have bipolar disorder, you see you have the odds ratio is higher, and this is compared to the general population. So it almost doubles. And the same you have it with anxiety disorder. So having a psychiatric condition, again, be it bipolar, being an anxiety disorder, increases the risk of substance use disorder, including alcohol dependence. Now, this is in terms of uh, cannabis dependence. It is interesting. In New Mexico, marijuana was just approved, or it's legalized rather. Was that a good decision? Yes. Why do I say that? Because I think it is better for law enforcement to spend their time following narco traffickers or people who commit crimes as opposed to adolescents who are smoking marijuana. And of course, in New Mexico, marijuana is legal, but it is after over the age of 18. And does marijuana have an effect on the course and outcome of bipolar disorder? The answer is yes. Studies have shown that adolescents who use marijuana, the age of onset of the condition is going to be at a younger age. In addition to that, patient with bipolar disorder who uses marijuana, the chances of relapse are higher. Now, I'm not an expert in treatments with marijuana, but many of my patients tell me that it helps them with anxiety. And if they say they do, I guess I believe them. But it has other risks. So as you can see, in a history of generalized anxiety disorder, the risk of having marijuana dependence, as you can see, is very high, and same with bipolar disorder. So it can definitely affect the course and outcome of bipolar disorder. Now, this is what I like to call the trio, which is the most common presentation of a patient with bipolar disorder is a patient who has, and in this case, we're talking bipolar 1, who has, in addition to the bipolar disorder, substance use and an anxiety disorder. That is very, very frequent. So again, it is very important that when we have a patient with bipolar disorder, we always complete a good medical history to find out if there's another condition, be it psychiatric, be it substance use, and as mentioned before, medical. So this is the most frequent presentation of patients with bipolar disorder. Here you have another common comorbid condition, which is impulse control disorders. Many of our patients, when you do the history, will tell you, and I'm talking about our patients with bipolar disorder, they will tell you that when they were young, they were hyperactive, or that they were diagnosed with ADHD. And look at that. A third of patients with bipolar disorder, a third have stimulant use disorder, ADHD. And as you can see, both bipolar 1 and bipolar 2. This again brings a very challenging treatment decision. What is the treatment for impulse control disorder for ADHD? Stimulants. What do stimulants do to the course of bipolar disorder? It can contribute to cause mania. Is it, are stimulants contraindicated in bipolar disorder? The answer is no, they are not, but we need to be very cautious. I will never forget, I was asked to be a expert witness in a legal case where a patient had bipolar disorder and also attention deficit disorder. And when he didn't take his stimulant, he had trouble concentrating, focusing. He had a job where concentration was important. And very unfortunately, this patient committed or died by suicide. And in a very bloody way, he stabbed himself a number of times. The patient had a family, children, and so on. So when we went to court, a key question that was asked to the psychiatrist treating the patient: did you let the patient know that using stimulants would increase the risk of impulsivity? The answer was, unfortunately, no. So again, it is important, if we're going to use treatments like stimulants in patients with bipolar disorder, the decision should not be just ours. We're going to give you this medication. The decision we want to do collaborative care, which means that the decision ultimately is made by the patient. Will I take the risk or not? And the family. And in that particular case, there had been no warning in terms of the risk. Again, not contraindicated, but use them very cautiously. Let's now talk about multiple conditions. And we mentioned before, we mentioned that the most common is the trio, but you also have this, I guess, quartet, where you have bipolar disorder, anxiety, substance use, and ADHD. This is actually not unusual. And again, the number of treatment challenges. Of course, the best treatment is not just medication, but medication and psychotherapy. So it is key to make sure that we're treating all conditions, because if if we don't treat one condition, that's going to affect the others. I would add to this graph also medical condition. Be it, of course, we know that bipolar disorder, we used to think it was a condition of the brain or the soul. Now we know it's of the body. Studies have shown that patients with bipolar disorder, there's an issue with inflammation that leads to conditions such as hypertension and diabetes and so on. Patients with bipolar disorder have a higher prevalence of diabetes or hypertension compared to the general population. So let's look at all the comorbidities. So this is when you talk about prevalence, you have actually lifetime. You have also current. Current is at one point in time. Lifetime is, of course, in the lifetime of the individual. And another term that is used frequently is 1 year prevalence. So or 1 month, whatever, 5 years, however you want to define it. So the colors, as you can see, lifetime in this Venn diagram. What is this red? Well, there you go. Bipolar, attention deficit, and substance use disorder. That is, apologies, anxiety disorder. Anxiety disorder and substance use disorder. Here you have this trio. And then when you have in blue, there you do have the ADHD, substance use, and anxiety disorder. Here is lifetime. And here for this, what we call quartet, is current. So as you can see, the majority of patients with bipolar disorder, I know I'm repeating myself, but it's to make a point, have comorbid conditions. Now, this is a clinical sample. So in epidemiology, you have population samples. That is, you go door to door, like the study by Americangas, and interview individuals. Clinical sample is patients in a clinic or a hospital. Actually, one of the problems with population prevalence is that, as we know, the facilities with a larger number of patients who suffer from psychiatric conditions are detention centers. We recently here in New Mexico now are providing correctional care, psychiatric care for patients in the detention center. The majority of them suffer from a psychiatric condition. So one of the things that we've started doing is have, like we call it, bridge clinic. Individual is released from detention. Individual suffers from a psychiatric condition. Individual was getting antipsychotics while in detention. Patient is discharged or individual is released or detainee is released. It is essential to have a bridge to a clinic. Okay, so let's compare here major depression with bipolar disorder. And here we have any anxiety disorder. As you can see, it's high on both, a little bit higher in major depressive than in bipolar disorder. And here you have the different anxiety disorders. Substance use, the condition, the psychiatric condition with the largest prevalence of substance use disorder, folks, is bipolar disorder. Well, it's the mood disorders. As you can see in mania, and I mean in depression, 35%, but in bipolar, 63%. We also mentioned attention deficit. And sometimes we forget also about eating disorders. Look at this, 10% lifetime prevalence of eating disorders. So it's always important to, in patients with bipolar disorder, you need a very good medical history, psychiatric history, because you need to rule out a number of conditions because that will affect the course of your illness and, of course, the treatments that you're going to provide to the patient. So what is the impact of those comorbidities in terms of course? And as mentioned, anxiety, there's a negative impact in a number of ways. Patients with bipolar disorder, when there's comorbid anxiety, have an earlier onset of bipolar disorder. Now, this is interesting because I've mentioned marijuana. If used by adolescents, you have an early age of onset. I also mentioned preventive care. When I meet with the parents, with a patient with a first episode of mania, I see many patients like that in our first episode clinic. Usually the parents will ask is, well, what can we do to prevent our other children to develop bipolar disorder? And I tell them, just make sure that they don't smoke marijuana or any other substance because that will decrease the age of onset and, of course, worsen the course. There is anxiety. The symptoms of mood symptoms are actually more severe. When there's a comorbid anxiety, there's more frequent relapses, especially with depression. And by the way, depressive relapses are more frequent than manic relapses. And of course, they comorbid or subsyndromal symptoms are also key. So when you look at a treatment, it's not just preventing the relapse, it's also the subsyndromal symptoms, a little bit of depression, a little bit of mania. What has the worst functional outcome is a little bit of depression compared to a little bit of mania. Patients with anxiety disorders, comorbid, also have poor response to treatment, longer time in remission. It affects the time in remission, higher incidence of substance use if you have this the anxiety, suicide. So this is key in your patients who have also comorbid anxiety. The risk of self-destructive behaviors is larger. Obviously, there's going to be more challenges in diagnosis, complain more of side effects. So here is the impact of comorbid anxiety with euthymia. Euthymia, of course, the Greek word, that means the mood is good. As you can see, no anxiety disorder, the time in euthymia is longer. So with any anxiety disorder, you see that the time in euthymia is shorter. So it definitely affects it. It also increases the risk of suicide attempts, the comorbid anxiety. And here you have the graph in terms of percents of suicide attempts. In the absence of an anxiety disorder, it's quite significant. Look at the difference. No comorbid anxiety, and here you have patients with panic disorder or other types of anxiety disorder. So always be very, very careful with patients who have comorbid anxiety and in terms of self-destructive acts. This is in patients with rapid cycling And this is in terms of suicide attempts, as you can see, patients who are rapid cyclists, threefold larger almost risk of attempted suicides if there is any comorbidity. So here is also having a comorbid, in this case of anxiety, affects the likely to have a mood stabilizer. Let's assume that a good treatment in bipolar disorder is a mood stabilizer, say lithium. Uh, Lithium, sometimes we forget about lithium. We shouldn't. It's an orphan drug. That means there's no promotion of it. I always like to mention to our residents, every patient with bipolar disorder should have the benefit of trying lithium. Is that because lithium treats the majority of patients? Unfortunately not. But I can tell you when lithium works, it works great. And another key thing is family history. Okay, so a relative has bipolar disorder. Key question, what treatment is that patient getting? And if they tell you lithium and is doing great, that's where you should go. So never forget the lithium. So here you are. And this is patients with, as you can see, when there's an anxiety disorder, patients are less likely to receive a mood stabilizer. So keep that in mind. Now, what is the outcome, the impact of outcome? And I've talked a little bit about that. So this is patients with bipolar 1, and they are less likely to seek help if they have substance use disorder or they're misdiagnosed. Here, as you can see, the ones that are receive the right medication this is when there's no reason. As you can see, the right treatment is more common than those with substance use disorder. So it affects the condition, but also affects us as prescribers in terms of making the right diagnosis or not providing the ideal treatment for that particular patient. And also here is the patients with substance use disorder and non-response to lithium and also valproate. And as you can see, the response to lithium decreases when there's also substance use disorder. Here you have, I've mentioned a number of times earlier, onset, greater depressive symptoms. This is also in bipolar disorder. And as I've mentioned before, the symptoms of depression affect functioning more than symptoms of mania. Well, of course, when there's mania with psychosis, there's a great impact in functionality. More suicide attempts, functional impairment that is key, and this is another key one, medical comorbidities. So a big impact, and of course, it affects the life of individuals who suffer from the condition, including more legal complications. There's some obvious ones like driving while intoxicated. This is a review that we did a number of years ago in terms of the compliance, and this is something that we've mentioned, less compliance with medication. Now, this is a course. Let's talk about course. So first, why do we have such a high prevalence of substance use disorder in bipolar? It's not really clear. It's probably bidirectional. One condition leads to, if there's bipolar, there'll be a tendency to use drugs, but it's also most likely at a biochemical way, meaning that the disorder has some things in common. Early age of onset, and then you can see the other key thing is primary and secondary diagnosis. So the primary, one way to define it is what is the condition that appeared first. The other one is what is the condition that at some point is more acute, and that's how you should focus in terms of the treatment. So let's, again, preventive measures. So Here are some of the explanations of the association. Can mood disorders be secondary to this substance use? Well, it's again one of the variables. One of the reasons why we supports that the use of drugs causes a psychiatric condition is when you have head trauma. Something that we've been seeing lately here in New Mexico is the large numbers of patients who present with symptoms of bipolar disorder with recent use of methamphetamines. And there's studies that have shown that the repeated use of methamphetamines would lead to a psychotic condition that does not go away even if the individual stops using methamphetamine. Sometimes it's very difficult to make the differential diagnosis. Are the symptoms of mania or the psychosis secondary to methamphetamine, or is a primary condition? Unfortunately, many times it's both. But of course, the way to make the differential diagnosis is still time will tell. If the symptoms go away within 24, 48 hours, most likely it was an intoxication. But again, differential diagnosis is difficult. As mentioned, the pathophysiology in the neurotransmitter system might explain why the high prevalence of comorbidity. But this is still studied mostly in animals, but most likely it's related to the neurotransmitters. So let's talk about the outcome. So this is a key thing. I mentioned earlier, 60% of patients with bipolar disorder suffer from substance use, and here is the answer. And when you do it for this study that we did at McLean a number of years ago, when you look at first episode mania, the prevalence was 17%. When you follow that population for a number of years, more than 4 years, 60% of patients are going to be using drugs. So here's I would say, beautiful example of preventive medicine. When you do your psychoeducation with a patient with bipolar disorder and they are not abusing drugs, let them know about the risk and provide the education. So that's an example of preventive medicine. So in the majority, the onset of mania precedes the onset of bipolar disorder. And as mentioned, preventive medicine is key. The treatment, as we've mentioned before, it should be in the same location. That's why we have those clinics of dual diagnosis where the patient receives treatment for both conditions. Sometimes, of course, you need the experts, and we frequently do that when we have a patient with bipolar disorder and has a substance use disorder. We do get a addiction psychiatrist as a consultant, and the other way around as well. When in our addiction clinic, they have a patient who's showing some symptoms that suggest bipolar disorder, we, of course, are happy to provide our recommendations. So usually, as I've been mentioning, the treatment is separate and sometimes unrelated. So integrated treatment center in red, integrated, that is key to do. So the treatment approach, it should be specific and integrated. It should receive the treatment of both conditions. Now, something that is interesting is that we used to let's talk about self-medication, that patients, when they are depressed, they would take stimulants, and when they are manic, they would take alcohol or something. Unfortunately, that is not the case. It's not self-medication. We frequently see patients who, as I've mentioned before, in mania, they tend to abuse stimulants. So they get even more psychotic. So what studies are needed to understand more the condition? Well, longitudinal. I'm sure you got that message that we need to study patients at the beginning of the illness to determine how can we prevent secondary conditions. And also, sometimes we forget about the prodrome in bipolar disorder. We used to think of prodrome only for schizophrenia, But bipolar disorder, there's a prodrome usually, as I'm sure you can tell, anxiety and ADHD. So that's important too. That's why we will better understand a condition and we will better determine the best treatments and preventions. Outcome studies, this is what I want to illustrate here, is in patients with bipolar disorder. You see alcoholism, it is higher in terms of prediction of relapse to mania. So actually, I was just seeing a patient yesterday who asked if would alcohol affect the course of his condition, and the answer is depends. If the patient has once in a while a glass of wine, what have you, most likely not. On the other hand, if the patient frequently gets intoxicated, the answer is yes, there will be a higher risk of relapse. This is the study that I mentioned, that the prevalence, even in first episode, is high, but not as high as in multiple episode. Let me now mention again the recovery. And in this other outcome study, we found that the recovery is faster when there's lack of comorbidity. And that's something that you should, when you talk with your patient after treating an episode of mania, that probably if there's comorbidities, it's going to take a little longer as opposed without comorbidities. This is again the factors associated, in this case, of functional recovery. And again, as you can see, the lack of comorbidity is associated with a faster recovery. Just to wrap it up here, another thing that is affected is cognition. Sometimes when we think at cognitive impairment in patients with psychosis, we of course think of schizophrenia, but unfortunately, there's also cognitive impairment in patients with bipolar disorder, especially as they grow old. Some very interesting studies have shown that elderly patients with schizophrenia and with bipolar disorder, the risk of a cognitive condition is higher compared to the general population. So yeah, it does have long-term outcomes. This is, we did a review, and unfortunately, the finding was that if you look at doing a meta-analysis, 60% of patients with bipolar disorder, with substance use disorder, have cognitive impairments. And as you can imagine, the cognitive impairment increases with the substance use compared to patients without a comorbid condition. Just to summarize our presentation, there is a high prevalence, and it also a predictor of a poor prognosis when there is comorbid substance use disorder in patients with bipolar disorder. When we do the studies, we should look at how one condition affects the other in terms of recovery, remission. We need to do the evaluation of maintenance treatment. We should consider treatment the comorbid conditions, because the comorbid conditions are going to increase not only the risk of relapse, but something that I mentioned before, subsyndromal symptoms. Subsyndromal symptoms affect functioning, and as I mentioned, depression more than mania. We should very, very careful in terms when we do our medical history to ask about not only substance use in terms of recreational drugs or also in terms of alcohol. Refer those patients with comorbidities when needed to the appropriate treatment. Again, there might be times where the substance use is more acute. So those patients might need residential treatment or what have you in terms of leading them to sobriety. We need to educate our patients about the negative impact of substance use in terms of course for the outcome. And of course, abstention is definitely more important than in the general populations for the reason that we've mentioned. And the other thing that we mentioned, that the substance use in bipolar disorders long-term will affect condition, the cognition rather. So let's keep prevention, prevention. We should practice it, and especially in patients with bipolar disorder. So this is a beautiful picture of New Mexico. You have there the Rio Grande. I actually like to exercise, run to the river every day. It takes a mile, run 2 miles in the river and go back home. Keep myself healthy. Thank you, folks. Dr. Castman, if there are any questions, happy to address.
Thank you, Dr. Tohen, for sharing your wisdom with us, with 355 of us today. So 355 people out there. And I know some of you will have questions for Dr. Tohen, so please go ahead and use the Q&A function here to put those in. And Dr. Tohen, thanks again. So much to think about here. Let me start with one of the questions, and here they come rolling in. There's a question here, Dr. Tohen. It says, how often are symptoms like anxiety and impulse control disorder truly comorbid, and how often a sign that the bipolar disorder is undertreated? Like a very complicated question that I think you think about probably a lot in your role as a clinician.
It's an excellent question. The problem that we have in psychiatry is that to make diagnosis, we use phenomenology. We don't have biomarkers, and maybe we never will, or at least in our lifetime. So it's of course an important differential diagnosis because when it comes to treatment, I would say that when we have a patient with both conditions, let's say anxiety disorder, we will treat the bipolar disorder. If the anxiety goes away with, say, a mood stabilizer, that would suggest that is actually a symptom of the syndrome, as opposed to two separate syndromes. I think it's never going to be, as we like to say, black or white. It's going to be grays. But what I would say is, especially in a condition that is acute, treat your bipolar disorder, the symptoms that you're having, and if the comorbid condition, in this case anxiety, it doesn't go away, then consider that it is a comorbidity as opposed to symptoms. You could argue the same thing with depression. Is depression that the patient has relapse, or it's a mix, and that's why the valuable term of a mixed symptom that can happen within mania or within depression. Key question, especially not only for the point of view of diagnosis, but in terms of determining treatment. Same thing with ADHD. Is the patient impulsive because the patient is manic, or does the patient have a comorbid ADHD? And then, of course, I would go back to the epidemiology, which is still complicated because, as I mentioned, you can have the ADHD at a younger age. But then, as I also mentioned, is it the prodrome, or is it a separate condition? And again, complicated in terms of treatment. Thank you for the excellent question.
Yeah. So another question: if you're evaluating a patient who has potentially anxiety or potentially bipolar disorder, but who's up at night, not sleeping, with insomnia, are there specific questions or ways that you evaluate that symptom to delineate whether this is part of a hypomania or a mania versus an anxiety that's keeping somebody up at night?
And actually, to keep that question even more complicated, is it akathisia?
Is akathisia? Yes.
And of course, some of the new treatments in bipolar depressions of the second generation antipsychotics do improve the depression, but they also cause akathisia. So it is again a complicated question. I would say that again, focus on the treatment response. So if your treatment helped, and also in terms we also have a circadian presentation of symptoms, and that's also key. What also in terms of treatments is the best treatment for anxiety medication. I'm sure, Dr. Katzman, you would say, no, it's going to be psychotherapy, of course, in terms of the treatment. So those are challenging questions in terms of treatment that unfortunately, as I tell my patients, it is trial and error. We'll try this medication. If it worsens it could be that it actually is uh, causing new symptoms, or it might be a side effect of the medication. But important question to clarify.
So question here in a kind of uh, summary thinking about this. Mauricio, what would you say is the best treatment for bipolar disorder with comorbid anxiety when you're evaluating that?
Well, I like to say that it's best to be parsimonious. That's an equation with the least number of variables, meaning if you have one treatment, it's better than having two treatments for a number of reasons. So I would say that you go one by one in terms of your treatments and look at the response. I would, and also let's not forget about our psychotherapies. And frequently when I have patients with bipolar disorder in terms of, say, anxiety, let's try some therapy, cognitive therapy, what have you. Try to avoid medication because of the possible effects on the condition. Of course, SSRIs is a good medication for anxiety, but as we've mentioned, it can also increase the risk of having symptoms of mania when the patient is depressed. So don't forget about psychotherapy, I would say, or just even things that help with anxiety, like exercise. That's another key thing. Or I'll ask the patient, what helps you when you are feeling anxious about something? I can tell you, Dr. Kassman, when I'm feeling anxious about something, I run.
Yes, yeah,
And
down the Rio Grande under the balloons.
exactly, and it helps you.
Yes,
Yeah, let's not just think about pharmacology as my expertise, but let's not think of the other therapies.
great. At this, another question that kind of about risk of pharmacology is an interesting question. With so many of our children now taking stimulants for ADHD, could this lead to early onset of bipolar disorder?
Again, excellent question. And studies have suggested that, but it's complicated because is it the stimulant or is it that patients with, and this is a key thing, patients with ADHD or a history of ADHD tend to have a younger age of onset. This is in the absence of treatment. Now, could the combination actually increase the risk of a younger age of onset? I would say that that is certainly a possibility. I wouldn't rule it out. And this is why the collaborative care, we have, say, a minor, and when we talk to the parent, let's say the family, there's a sibling with bipolar disorder, and the younger sibling starts with ADHD. This is an important question, that it is possible that the age of onset is going to be younger, but as a colleague asks, can stimulants decrease the age of onset? I think that is certainly possible.
Great.
Apologies for my imprecise answer, but
Oh,
I guess
that's
we just don't know to what extent. That's the
yeah.
importance of research.
And Mauricio, can you teach us something about the briefly the genetic predisposition for bipolar disorder and increase in risk in family members and siblings is a question in the chat.
Sure. Well, there's no doubt that there's a genetic component in bipolar disorder, but I think it's always important to keep in mind that we are dealing with a syndrome, not with an illness. We call a condition an illness when we know the etiology, and in bipolar disorder we just don't. So the example that I made about lithium, when lithium works, it's wonderful. And there are studies actually coming from Korea that have shown that there, in terms of the, I'm not a biogeneticist, but that certain genes are different when their patients have a response to lithium. We will not find it's not a single gene, and actually it's always important to think about bipolar as a syndrome. In some cases, there's going to be more of a genetic component. In others, not. Studies that were done really more than 50 years ago with um, twins raised apart. Those that were you still saw twins who were homozygotic. If they were raised apart, the prevalence, the concordance was not the same. That means it's not only genes, it is also the environment. Trauma is another one. Definitely the risk of trauma, you could argue, contributes to bipolar disorder. On the other hand, you could argue, let's say in terms of children, parents with bipolar disorder, when they're not well, are they more likely to physically abuse a patient or a child rather, or their children when they're manic? It's certainly possible. So it's multifactorial. And again, in some patients, it's going to be more genetic, in others not.
Great, thank you. A few questions in here about the comorbidity of bipolar disorder and personality disorders or borderline personality disorder. And I know you probably think about this quite a bit in the middle of the night in the psychiatric emergency room. And what are you seeing? But what are your kind of just
Yeah.
coffee table thoughts about this and what you know?
There's a lot of misdiagnosis going both ways.
Mhm.
Is it comorbid? It's possible, but many times some of us are, as you mentioned, Jeff, the psych emergency service. Many times resident or staff will say, "Oh, she's a borderline," and again in a pejorative way. And when I see the patient, oh, this patient clearly has symptoms of bipolar disorder. There's family history. So it's a challenging differential diagnosis. The question was, can there be the comorbidity? Yes, but more importantly, and actually this is why the treatment would be different. So is pharmacology the best treatment for borderline? No. Now, have some studies shown improvement? Yes. So it has big implications in terms of treatment. So again, it could be comorbid, but most likely is however you want to call it. Folks might say that I might overdiagnose bipolar disorder. It's possible, but I've seen it the other way around as well, especially with in mild conditions.
So uh, a very nicely thoughtful question here. Uh, does the high rate of comorbidity in bipolar disorder, in addition to what we're talking about with personality disorders, raise questions about our nosological approach to psychopathology and might we be barking up the wrong tree in terms of how we actually conceptualize psychiatric diagnosis?
Meaning, let me make sure that I understand the question.
Uh,
That rather than thinking of two conditions, that maybe it's just one, and that
Yeah,
it's part of the, and again, it's going to be kind of a silver thing. And the example of anxiety, the first question was a key one. Is it comorbidity or is it uh, part of the condition? And this is, of course, the challenge that we have in our field with diagnoses that are phenomenological, what we observe or watch rather than any other way to make the diagnosis. Yeah, it's an interesting question. I would say that um, we clinicians, when we see a patient, should we prepare for both? And we should ask ourselves, is this really a comorbid condition that will need a separate treatment, or is it part of the condition? I think we should always challenge ourselves. Again, a challenge of phenomenology, Jeff.
Great, thank you. Question here. How does bipolar disorder tend to change or evolve with aging and with a geriatric population? Does it tend to result in a need to rebalance medication or increase cycling or um, yeah, what happens as we age with
Yeah,
bipolar?
yeah, great question. The answer, it varies. Uh, in general, unfortunately, and it really depends on the course of the illness. When you have a patient with a recurrent condition, that means multiple relapses. Uh, the when you look at studies, you will see that multiple relapses will lead to poor functioning. The more the number of relapses, the worse is the functional outcome. Okay, it's almost it's like if you have a rubber band, they say you keep stretching it. There's going to be a point that it doesn't go back to its usual size. It becomes longer. So yeah, that is clear. The other thing is, and that I've mentioned in terms of cognition, the studies have shown that multiple relapses will lead to functional poor outcomes and also increased risk of cognitive deficits. And that has been seen both in bipolar and schizophrenia. Now, there's another very interesting concept, well, not concept, condition, which very late onset bipolar disorder. So in general, bipolar disorder, the age of onset is late teens or early 20s in general. You see it in the early 30s, you see another group. But we do see patients who we have a paper a number of years ago, very late onset patients over 65 with the first episode of mania. Those patients had a history of anxiety and depression when they were younger. And then as they grew older and there was something neurological or hypertension. Here, anytime you see a very late onset mania, get your neurology colleague. There was probably some mini stroke and something, or something that happened that led that condition become a first episode of mania. It's actually not that unusual. But yeah, what does not happen is, and we don't tell our patients, oh, it'll get better with time. Do we sometimes have such patients? Yeah, less than 10% of patients have a single episode only. So of course, after an episode of mania, it'll get better with time. It won't go away. When can you tell the patient that they are the lucky ones who have a single episode only? I would say that you have to wait at least 4 years. Studies done before psychopharmacology show that if there is no relapse within 4 years, the likelihood of having a relapse is very, very, very small. So just to summarize the answer, in general, worsening, but not in all cases, unfortunately worsening. Let's not forget medication. Our medications are not perfect. They cause obesity and so on. So it decreases. So the risk of medication and contributing to the worsening of the condition is also a possibility.
Mhm. You mentioned in passing this idea, Dr. Tone, of inflammation as maybe emerging as some in some degree as causal when you were talking about an association with the body of high blood pressure and diabetes and other issues. Do we know much about in body inflammation and its relationship to causality or anything else with bipolar disorder?
Yeah, I've been reviewing grants recently
Mm.
and asking that specific question. For instance, there is remember a study that was looking at uh, denture inflammation. And patients with bipolar disorder tend to have more uh, dental problems,
Mm.
infections, inflammation, and so on. So that was they were trying to show that there's if you look at other parts of the body, you will see more inflammation defined in a biochemical way than in the general population. Yeah, there's two good studies going on.
Mm. Um,
Now, of course, the question would be, do we have a biological test that will tell us that there's a risk of inflammation in the body? Uh, it's not ready for prime time, not at a clinical level, but there's studies looking at that. And that might be key, and not only in terms of diagnosis, but also in terms of prevention.
Great. Many comments coming in, Mauricio, about saying great talk. So let me just tell you tell you that and thank yous. So let me get to a few more questions here before we close. One, just general questions. I think the general question for the expert, in your opinion, is recurrent depression better treated with unipolar or bipolar medication?
That's an interesting question, and let me show you a book that I have here. Uh, Goodwin and Jameson, and then it is manic depressive illness. And one of the points that it's made in the book is that recurrent depression is most likely part of bipolar. So that is an interesting question in terms of is recurrent depression more within the bipolar sphere in terms of etiology and treatment? Well, some would suggest and some studies would suggest. So that means that actually, as you well remember, Jeff, we have a TRD clinic here, treatment-resistant depression. The most frequent reason of a TRD patient being referred is that the patient had bipolar depression. That is it's a very frequent diagnosis. So anytime that you have a TRD patient, make sure that, especially bipolar twos, do a good history. Are there episode of hypomania? So that, in a way, refers to the question that what appears to be a recurrent depression might be a bipolar 2, and the treatment is not going to be your antidepressant. It's going to be some of those new drugs that we have around now that are good in treating bipolar depression.
Great. Thank you. Another question, if you're up for it, there's some evidence of increased incidence overall in schizophrenia with high potency cannabis. Do you think that high potency cannabis and stimulants might be changing the actual rates of mood disorders and not just the age of onset?
Can you repeat your last question?
Yeah. Could high potency cannabis and stimulants maybe actually changing the rate of mood disorder presentations, and not only the age of onset, but are they creating a greater number of mood disorders?
Yes, I do. And in fact, especially the stimulants, especially methamphetamines. So that has, as a colleague mentions, not only decreased the age of onset, but actually increasing the prevalence. You see now a number of individuals without any history of bipolar disorder or psychosis, recurrent use of stimulants, especially, and that leads to a psychosis. So can psychosis be environmental? Yeah, and this would be an example. Now, the cannabis, uh, I think what most of the studies show is that it depends on the stage of the brain development. And
Mhm.
certainly, if it's used at a young age, it increases, not only decreases the age of onset, but also I would say the prevalence. Now, when used at a older age, would it increase the risk? Well, as everything in life, psychiatric conditions are multifactorial. I wouldn't rule it out. I don't have a precise answer, But would I say no? No, I can't say no. Definitely stimulus. Marijuana, uh, it's possible. I think that's a safe answer. It's possible.
And and do you find emphasizing all the risks of relapse with patients improves adherence to treatment in your clinical experience?
Oh, definitely.
And any advice for emphasizing the risk of relapse with patients with comorbid substance use?
Well, I like to uh, show them graphs. So sometimes what I do, I show them a Kaplan-Meier curve that shows the difference of relapses you have with substance abuse or use without. So there it is. If you use drugs, the likelihood increase. I always correct. This is, of course, on average, and it's with a number of patients. Can I assure you that that will happen to you? I can't. But in terms of probability, for sure. Yeah, I actually, that when I talk about psychoeducation, that's how I do my psychoeducation, sharing studies. And you know what? A great thing about our times is democratization of knowledge. Our patients sometimes know more than we do, and they read and they know about medications, they know their side effects. One of the, and I see that more with medications, but I think that when we to increase adherence, that definitely helps. I've seen it, and in fact I do it absolutely.
So some recently
Let
you've
me
been,
let me just
yeah.
forgive me for interrupting, Jeff. Long-acting intramusculars. We tend to think that we should only use them in chronic schizophrenics. The most non-adherent patients are those who suffer from bipolar disorder.
Mhm.
So is a long-acting intramuscular a good treatment? We shouldn't forget them. The problem with the long-acting, the available ones, are not that good, or they're not good in preventing depression. They're better in preventing mania, but not in depression. But then again, we can have the combination and have the long acting as an anchor, especially when the predominance is mania. Even, you know, when I first introduced the question of a long acting, once there's the second episode, and it had to be with non-adherence. First episode, the last thing we should do is, you're doing great, I'll see you in 6 months. Mistake. You know what's going to happen? The patient is going to stop their treatment because they're having side effects and no symptoms. So it is important to follow patients closely. And once they start with the non-adherence, and also not only non-adherence, convenience. I have patients who, of course, go away on weekends and then they want to take their medication, they'll forget. So it's convenience. So let's not forget the long actings for bipolar. But
Some
again,
re
let me emphasize, not good in preventing depression, but good in preventing mania.
Mhm. So 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 a question here about the impact of uh, COVID on patients with bipolar disorder and on treatment with bipolar disorder. And so there's that question. And yeah, and I would also just add in there your experience as a seasoned psychiatrist, leader, chair in what's happening to us uh, as a result of COVID, and your kind of sense about that.
Well, and let's not forget that you've done a lot of work there, Jeff, with
Mhm.
the effects that COVID has had on loneliness and so on. Actually, there's studies going on showing pre and after COVID. There is no doubt that COVID, of course, contribute to isolation. It is, of course, clear that isolation, there's exceptions, but in general, increases the risk of depression. So I would say that COVID, that when isolation was needed, and I'm not being critical about isolation because that from an infectious disease point of view, it helps. But definitely, I would say that COVID, then there's the other thing, long-lasting COVID. Studies have shown that patients who did not show depression before, after they suffer from COVID, there's more depression. And even in those who isolation was not a factor. So I would say yes. And there's some, actually, there's a number of studies going on that are looking at that. But I would say definitely it has affected. It's not going to be the last infectious epidemic that we have around. We've learned a lot. Actually, the silver lining is telemedicine, or what we're doing now is giving a lecture. We all feel very comfortable using telemedicine thanks to COVID. That would be the only silver lining. So again, Jeff, I would say yes. That I wouldn't say in every individual, but it's one factor that will worsen the course.
Great. So uh, just in ending, you mentioned the impact that a mentor had for you in terms of giving you the advice of following your passion. And so you have 350 people around the country here, and I know you. I don't want to put you on the spot, but if you had some words of wisdom around people and their career development and what you think is important, any kind of some experience as a clinician and a researcher and an administrator, what would you tell folks, or what would you tell someone?
Thank you, Jeff, for this very challenging
Yeah,
question. It really depends on when folks are in their life. I also like to say that mentors is not one mentor. It's best to have more than one. Peer mentors are key. My peer mentor is my dear wife. I run everything through her. She advises me. But back to psychiatry. I think especially those of you who are starting your career, uh, mentors are key, peer mentors, and more than one mentor. Those of you who are planning on having an academic career, or even not an academic career, but let's say not within a private practice or we're working in a group, a promoter is also key. A promoter is different than a mentor. We know the term promoter of boxer, people who do boxing or jujitsu, what have you. That's a promoter, find their fights. So find someone who's going to help you in terms of a new job opportunity, letter of recommendation, and so on. So promoters are key. I was very fortunate that I had two great promoters, Ming Swang and Roswell Desarini. I love them dearly. Now, when we get more seasoned, I'll tell you, especially when you come from academia, sometimes you're not a very the ideal leader, because when you're in academia, you my grant, I'm the lead author, and so on. But I can tell you that a key thing about leadership is uh, it's an opportunity. It's very rewarding to help others, and that's something that I've discovered. Like when you've had your grants or your publication, Jeff, it's vicarious satisfaction. So as we age in our careers, it would be a missed opportunity if you don't enable yourselves to help others. And I can tell you by experience, and that's something that with time or age, what have you, I've learn more about and enjoy more. Also, when we treat our patients, I love seeing patients. It's very rewarding when you do something that is going to improve the life of those patients. So again, it depends on that career. Difficult question. I kind of ramble around a little
you
bit.
did
Sorry about
beautifully.
that.
I couldn't resist, and just much gratitude for being one of mine and so important in my life, and for all the encouragement that you gave to me along the way. And I say that really as a way to kind of spread the modeling to all who are listening. You know that we
Un,
affect each other.
un, un
Absolutely.
fuerte abrazo, as we say in Mexico, Jeff,
Sí, gracias,
my dear friend.
mi amigo. All right. So as
See
we
you,
end
folks.
here.
Stay well.
Yes, thank you, Dr. Towen, and now we'll end abruptly, and we'll all be alone and returning to our desk. Hopefully we'll see you all in a couple weeks. We'll talk about loneliness. A link will come up for the CEU and CME for everybody, and thank you all for joining in. And again, Dr. Tone, thank you. And there are many, many thank yous and great presentations rolling in into the chat that communicate your way.